Thank you for choosing CT product from Synovision. Today, we will introduce the scanning procedure of the coronary CT angiography. The coronary CT angiography, also referred as CCTA, is a non-invasive method to image the coronary arteries. The CCTA is used for diagnosis of coronary artery disease, also called CAD, preoperative coronary assessment prior to non-coronary cardiac surgery, evaluation of post-stent, evaluation of coronary bypass graft patency, evaluation of cardiac structure in adult congenital heart disease. The CCTA exam needs to be scheduled. The information about patient's heart rate and the presence of an arrhythmia should be known in advance. Only the patients with the allowed heart rate is recommended to perform CCTA study. Premature beats, atrial fibrillation, tachycardia, and any irregular cardiac rhythm often cause CCTA exam failure. Only occasional atrial premature beat is accepted. Besides the preparation procedures of enhancement CT exam, patients for CCTA study should come to the radiology department at least 1 hour in advance for preparation. More precisely, to take medicines, to have the intravenous catheter inserted, and so on. Heart rate control is the key to a successful scanning. The heart rate requirement varies by CT scanners. In clinical use, it is recommended that the heart rate should be no more than 75 beats per minute for Incidem 768, no more than 70 beats per minute for Incidem 568, no more than 65 BPM for Incidem 64, and no more than 60 BPM for Incidem 64S. Under normal circumstances, beta blockers should be prepared in advance to control the patient's heart rate. In addition to reduce the heart rate, beta blockers also have the function of stabilizing the heart rhythm. Let the patient lie down on the scanning table with supine position, and insert one end of the ECG cable into the built-in ECG gating socket on gantry. Because the other end of ECG leads are the snap leads design, it is recommended to snap on the electrode pads first, and then stick the electrical pads onto the patient's skin. Note that lift the patient's arms to the standard position prior to sticking the ECG pads to patient's body. The electrode pads should be placed on patient's body as shown on the picture. Place the LA, black electrode, on the first intercostal space of the left midclavicular line. Place the RA, white electrode, on the first intercostal space of the right midclavicular line. Place the LL, red electrode, on the xiphoid appendix level of the left midclavicular line. After the connection is successful, the ECG waveform and the corresponding heart rate will be displayed on the screen of the gantry. It is essential to minimize respiratory motion during image acquisition. The patient's corporation during the scan is the key factor to a good CCTA study. Normally, the acquisition time for a CT with 4 cm collimation is less than 10 seconds, and 2 cm collimation is about 13 to 15 seconds. So respiratory training is very important. We must let patient to practice the breath hold repeatedly prior to the scanning. The respiratory navigator assistant on the LCD display of the gantry can be used to assist the training. Pay attention to the vocal prompt in the demonstration, which should be as consistent as possible with the actual scanning. Make sure the chest and belly are completely still. Do not tremble up and down while holding the breath. Meanwhile, it is necessary to observe the changes of the ECG waveform when the patient holding his or her breath. During the breath holding, if the heart rate is too fast or fluctuates more than 10 beats, you need to continue to observe and adjust to ensure that the heart rate must be stable and below the specific beats. In order to let us understand the patient's breath-holding coordination more intuitively, we have built-in respiratory gating. As long as the subject connects the ECG lead according to the process, the respiratory oscillogram can be seen on the rack display screen and the scanning interface. The stable display of the respiratory waveform graph indicates that the patient has high breath-holding coordination. It's recommended to use a double syringe power injector with heating function for the cardiac imaging. Contrast agents with concentration of 350 or 370 mg iodine each milliliter are recommended. The injection volume is depend on the patient's weight, collimation width, and should also refer to the instruction of contrast agents. About 55 to 75 milliliters injection volume depending on CT scanner, with flow rate at 4.5 to 5 milliliters per second. Followed by a subsequent injection of 50 milliliters of saline with flow rate at 4.5 to 5 milliliters per second. Above is for average patient weight. More injection volume or higher flow might be necessary depending on patient weight. Please prepare the injection protocol on your injector in advance. In daily work, we usually encounter teaching, training, display function and other situations. Because coronary artery scanning must collect ECG waveform before analog scanning, we can use the built-in ECG simulation function to carry out simulation scanning. In the main interface of patient scanning, we can click the daily kit in the lower right corner of the screen, select System Config, select Other, select ECG Simulation, and click the checkbox before starting the ECG simulation activation box to show that the setting is successful. At this time, the ECG simulation function is activated, and then enter the scanning interface. We can see that the scanning interface has the ECG waveform simulation display, and the ECG waveform display area will have the font prompt of demo. At this time, we can carry out the complete simulation scanning process. After the simulation scanning, we should remember to return to the daily kit, System Configuration, Other, ECG Simulation Interface, and turn off the ECG simulation function. Next, please allow me to introduce the operation of CCTA scan. Type in patient information. Choose the scan protocol. Enter the scanning interface. We can see that the ECG waveform and the heart rate test button appear at the top of the screen. The heart rate test is to measure the maximum, minimum, and average heart rate over a period of time. The scan parameters are adjusted based on the average heart rate automatically or manually. After pressing the heart rate test button, there will be a testing process that lasts for 10 seconds. An automatic vocal prompt will be played to instruct the patient to hold breath. Once started, please do not perform other operations. First, perform a SCOUT scan. The CCTA scan is recommended with dual view. During the scanning process, you can see the indication of exposure status on the ECG waveform. When the X-ray is on, the curve turns yellow, and in white when X-ray is off. After the SCOUT scan is completed, first perform a non-enhanced coronary calcium scan, which is a prospectively ECG-triggered scan mode, and the scanning range should be set in both AP and lateral SCOUT views. This sequence is to detect the quantity of coronary artery calcium, for assessment of the calcium plaque burden. Also, allows patients to get familiar with the breath hold commands, and be prepared for the subsequent enhanced scanning. In addition, to verify whether the set scan range would meet the requirement. The next step is to perform the contrast enhanced sequence scan. Starting with define the range of the CCTA sequence. It's recommended to use bolus tracking for the contrast scan. First perform the locator scan. Place the monitoring slice at 1 cm below the tracheal bifurcation, or place the monitoring slice according to the results of coronary calcium scan sequence. After the locator image appears, recommended to place the ROI on the descending aorta. Before hit start for the next sequence, tracker scan, please make sure that the delay time in tracker scan sequence is 8 seconds, and the recommended threshold is 120. The delay time of the enhanced sequence, which is a kind of retrospective cardiac scan, is set to the minimum delay, or 5 seconds. Usually, the default diastole phase in recon sequence is set to 75%, and the default systole phase has been set to 45%. If the heart rate is higher than 65 BPM, multi-sector reconstruction can be considered. The maximum pitch reference is in the table. For example, if the heart rate of the patient is 68 BPM, for the Incidem 568 system, the pitch can be 0.22 or less, such as 0.20. For the Incidem 768 system, the 0.18 pitch is recommended to ensure that both single-sector and multi-sector reconstruction can be performed. When we are not sure whether single-sector or dual-sector is better, you can try to use Auto for automatic sector reconstruction. The system will automatically select sectors for reconstruction according to scanning parameters and heart rate information. Once pressing the Start button, the green Ready for Start indicator on the CT box would start blinking. Now, press the green button on CT box and the injection key on the power injector simultaneously. The system will run a continuous monitoring scan. When the measured CT value in ROI reaches the threshold 120, the scan of the CCTA will be triggered automatically. In special occasions, it can be triggered manually. When End Study on the upper right becomes black, the study can be ended. After the study completion, if the result is not satisfying, the offline reconstruction can be initiated to search and define the best phase. On the ECG waveform, the light blue areas indicates the data required to constitute the cardiac phase. Different from the offline recon interface in common, 2 additional parameter panels will be available in the offline cardiac reconstruction interface. On the third parameter panel, we can look for the optimal phase manually, and the optimal phase recon can be performed on the second parameter panel. For example, if we are not satisfied with the 75% default phase, we want to choose an optimal phase between 35 to 80% with a 5% interval. Then enter 35 in start phase and enter 80 in the end phase, which means 35 and 80 are the begin and end phases. Increment is 5%. Select the preview position. 50% represents the percentage of the preview position within the entire imaging range. This value can be calculated by the number of overall images or table location. For example, the page number of current image is the 58th. The total number of images is 192. 58 divided by 192, and the result is 30.5%. Then enter 30% in the preview position, and then click Preview. At the same time, we can see a white horizontal line on the scout image on the left, which is the preview position. In the preview view, you can see the images of different phases, from 30%, 35%, 40%, 45%, 50%, until 80%, and the specific phases information is displayed on the upper right corner information. It allows to repeat the preview processing several times until best phase is found. Finally, 51% is considered as the best phase. In this case, switch to the second parameter panel, and manually enter 51% in phase to perform reconstruction. The segment selection will be available here as well. After inputting the parameters, press Recon to generate the optimal phase image. In the cardiac reconstruction interface, We can also try to use the auto phase selection function. The system will automatically analyze the ECG signal of the current scanned image and reconstruct the image. The lower part supports the multi-phase reconstruction function. After activating the checkbox, we can input multiple phases according to needs. And at most 10 images with different phases can be reconstructed at one time. If encountered the occasional atrial premature beats, the ECG editor tool might be helpful. The operation can be also performed in the offline recon interface. Copy a series. In the new series interface, we can see the ECG waveform is displayed on the upper right corner. The R wave is corresponding to a small dot. Select one dot. Double-click the right mouse button to delete the dot. Double-click the left button to add one dot. Press and hold to move forward and backward. The aim of ECG editing is to make every small dot corresponding to one normal R peak. If there is an premature beat occurred during scanning, usually you can delete the dot corresponding to the abnormal R peak. ECG editing is only suitable for mild and occasional premature beats. It is not suitable for frequent or severe arrhythmia. Therefore, it is extremely important to determine which patients are suitable for a coronary CTA before the examination. Eventually, we have a good coronary tomography image, which can be sent to post-processing application for further analysis. The coronary CT angiography scan has been introduced here. I hope this video will be helpful to your work. Have a nice day. Thank you.